Good afternoon, everyone, and thank you for coming. Again, we want to showcase resources, services that are available here at Hoag that you don't have to go very far to reach excellence in care. It seems appropriate on Good Friday that we be delivering a topic on dying and care of patients nearing death. We've had a program for the adults since 1999. Our Palliative Care service began then, long ago. And we came from, start with one person, went up to now a whole team. And Dr. Vincent Nguyen on the bottom list was a part of a search committee that we selected him to be the director now of the program. And we were developing this in 1999. Someone said, do you know about the program going up in the nursery? Where they had this whole program called Resolve Through Sharing, comes out of a hospital in Wisconsin, on how to take care of parents when they've lost their baby. And so now also to recruitment, we have Dr. Marlon Mills, who has come on board within the last year or so as director of Hoag Maternal Fetal Medicine, a combination of interesting problems that you'll learn about today. Just briefly, this is their comparison in their education and board certification. Board certified in the field for which we've asked them to come and speak and address this topic. They're going to be kind of a tag team today with two of them. Dr. Mills is director here at Maternal Fetal Medicine at Hoag Hospital. He's part of the perinatal loss team of nurses, social workers, and physicians who take care of the needs of patients families who've lost the baby. And beginning a new program that's rather unique, it's perinatal hospice, where the expectation is that the baby has a problem that it will not survive beyond the womb, but how do you deal with this expectation in preparing the family, the parents, the grandparents, the brothers and sisters, and the like. Dr. Mills has a number of publications related to this work. We get very complex mothers who come in here and need special attention how to care for them in the best way with the greatest safety for the parent, the mother, and for the baby. Dr. Vincent Nguyen has been here in Southern California for a long period of time, very involved with geriatric care. We recruited him where he was head of the program at Monarch Hospital, where he's developed a whole program of advanced directives being developed at the nursing homes and with the ambulances and with the hospitals that they work with as well. Publications for Dr. Nguyen are listed here. And I'll skip over them for lack of time, as we want to get them involved up here at the podium and not me. So in front of you, you have the evaluation form that we tell you what these gentlemen are going to approach today, and I think we begin with Dr. Nguyen.
Well, good afternoon. Thank you very much for having us today. And I never had an opportunity to present with a perinatologist before. When Marlon and I sat down together, we thought about how we're going to do this. What are we going to, perinatology and geriatrician, how do we fit? And let's see if we can put together something. I just want to share this with you. So anyways, what we came up with is this, the title of our talk is on palliative care at the beginning and at the end of life. So I want to just go for a framework and just to build a frame for us to build upon this talk. We know that medicine is always geared toward the service of life. And in situations where we can't cure the patient and when the situation becomes so dire, we should be the director of treatments toward alleviating the suffering of the patient. However, when we see that when we refuse aggressive treatment, it's not seen as a rejection of the patient, nor his or her life. And so we see that the treatment decision to begin or to continue treatment is not based on the value of the patient's life. And oftentimes, this is the concern that we have when we care for patients and when palliative care is involved, is like, we put patients DNR and we want patients to die. No, we don't. We want patients to live and give them the best care possible and to help prolong life. And so the question, however, we ask is whether or not the medical intervention is beneficial for the patient and family. So the decision to either forego or to halt the treatment is really the decision whether or not the treatment is ineffective or disproportionate to the aim of sustaining life or recovering health. So whatever we do is about respecting the patient, and sometimes at the end of life, not sometimes, but all the time, we should be focused on delivering palliative care. And so how is this different from euthanasia or physician-assisted suicide? And this slide, this portion will speak to it all is euthanasia eliminates the person instead of leaving the individual suffering, and we don't practice euthanasia. So with that said, I'd like to introduce Dr. Mills, who's going to be talking on perinatal hospice, end of life at the beginning of life. Thank you.
Thank you. Yeah, this is kind of a different topic for an obstetrician to be talking about, because most of you all consider that job, although sleepless, usually very rewarding. And our experience as a maternal fetal medicine physician doing consultations, high-risk complicated pregnancies, when I was actively involved in the clinic before I moved here, it was pretty much daily that I was telling a patient that either she had lost her baby, had a baby with severe malformations that would involve multiple surgeries or care, or indeed a baby that would not survive. So in our world, it's actually a very common event. The disclosures, Dr. Selicki also mentioned, have nothing to disclose. What I do want to try and go through is to begin to lay a foundation of what those patients that we deal with face in terms of decisions and what they look at, review the impact of perinatal loss, introduce the concept of perinatal palliative care, and then look at some tools in terms of how do you talk to, what do you do with patients who have indeed suffered a loss. As Dr. Nguyen mentioned, there are ethical issues that we need to deal with, and those have to do with the maternal beneficence, and we all are very keen in removing harm, preventing harm, doing no harm, but also when we can do good, and that's a part of this thought process as well. I'm not going to go into the discussion about what do you do if moms who have a baby that clearly is not going to survive yet want very aggressive interventions regarding delivery, sort of beyond the scope of the time frame we have, but that is a sort of side issue to this process. And in that issue, having respect for maternal autonomy, being clear there either is or is not fetal beneficence and that aggressive care, and then respect for physician autonomy to be involved or not in that process. Again, we're not going to go into that in detail for this discussion, but are issues. So we see, like I said, this issue commonly with us. About 50% of fetal anomalies are diagnosed during the course of the pregnancy. Some of those we can definitively diagnose as being related to chromosomal or genetic issues. Some of those can be syndromic in nature. Some of those are without a defined syndrome and yet have very complex physical features such as anencephaly. We've been in the realm of fetal therapy, fetal diagnosis since the mid-1960s, and with evolution of ultrasonography, ultrasound techniques, we're learning more and more and more about the fetal anatomy and detail, and can pick out many more of these complex issues to discuss with patients before delivery and actually begin to plan management long before then. Again, beyond the scope of this discussion, some of the other tools we use in looking for these issues are a variety of screening programs and processes that help identify babies who may either have chromosomal abnormalities or some other form of congenital abnormality. But all of these put us in the realm of having this discussion during the pregnancy, and then dealing with babies or dealing with mothers and families after the pregnancy is over and a loss has occurred. A normal, healthy, otherwise uncomplicated woman who is pregnant has a 2 to 3% chance of having a baby with major anomalies, without regard to any other medical conditions. You start adding conditions like severe diabetes, and you increase that as much as 2 to 3 to even 10-fold. So there are a number of these issues that are related to loss. And again, many of those will be related to birth defects, malformations, chromosomal abnormalities. This is a short list of a few of the conditions that are considered lethal, in a sense that beyond the delivery, beyond the support of the mother in the uterus, these babies will not survive. Now, the exception possibly to this is trisomy 18. Some of these babies do survive varying amounts of time that could be measured in months and even years, but are typically profoundly affected, profoundly handicapped. But these others are very much associated with babies that predictably are not going to survive for a variety of reasons. Excuse me. So when I first gave some of this presentation, Dr. Selicki was quick to comment, you guys have a lot of acronyms. And so this is one that was in this particular study. This is termination of pregnancy for fetal anomalies. And this study was done and reported in 2009. And it looked at a large number of pregnant moms. And within this group, those moms that had severe fetuses had severe central nervous system anomalies. 72% of those moms opted for pregnancy termination. And when they were all evaluated after that event, there was a significant occurrence of sadness, guilt, anger, search for meaning, depression, post-traumatic stress disorder. There were very much an emotional burden to having gone through that experience. However, if you ask those patients, 88% of them would still have made the same decision given their options at that time. In another group with similar experiences in termination, 92% had no doubt about the decision they made, and 90% had no regret about their decision to terminate. But 17% of those moms suffered from post-traumatic stress disorder, and a significant number of the fathers also suffered from PTSD and depression as well. So it is a decision that does carry a burden, obviously. In that group of patients, some of the things that reduced that potential risk were those patients who had higher education levels, those patients who had good partner or family support, those pregnancies that were terminated earlier, so there had been less times in some sense for moms to bond to baby, those conditions that were clearly incompatible with life, so there really was only a shortening of or changing of the time frame at which the fetus would expire, and then having other children to distract and carry on with the family. When they looked at recommendations from those individuals that actually went through the process of terminating the pregnancy, what they recommended and what they found useful or wish they would have had would have been protocols, some way to provide the supportive care, continuity of care, so same individuals as much as possible involved, appropriate education, giving appropriate literature, helping them understand what to expect from the process, memories, being able to preserve those memories that now we're not going to be able to create new memories, so keepsakes, other of those sorts of things. In that continuity, arranging for follow-up, and Dr. Selicki mentioned the Resolve Through Sharing program. Part of their program is follow-up at key periods of time, up to as much as a year after the event. And then demonstrating genuine empathy, so being able to listen effectively, not being afraid of a therapeutic touch, and simply being with those patients after that event was all important. I apologize for this. This is allergy stuff. So I want to present very briefly a case that sort of highlights some of the issues and things we have to deal with this. And this is a mom that I saw about 6 months before moving out to this area, and it really does highlight sort of the next part of the presentation of what we want to achieve, and the dilemmas of not having this kind of a program available. 25-year-old first-time mom came in at 18 weeks to her general obstetrician, who diagnosed multicystic dysplastic kidneys. So these kidneys are non-functional. Most of the amniotic fluid around babies is urine, so this baby is not making urine, so this baby has complete absence of fluid. That fluid is necessary, so one, not only does baby have no kidneys, the baby will have lungs that will be incompletely developed and be unable to breathe and exchange oxygen enough to support life for the size of the baby will be, so we'll have severe pulmonary hypoplasia. For them, pregnancy termination was not an option. She was told by her physician that at some point in time, because there's no fluid around baby, because of this, baby will expire, and at that point, we'll go ahead and induce you, okay? She came to our office now at 35 weeks, almost 35 weeks gestation, with the baby still alive. Baby still has multicystic dysplastic kidneys and still has no fluid, and now what we see is a very narrow bell-shaped chest that is indicative of severe pulmonary hypoplasia that these infants get. They don't have any lung development, so the thorax and chest stay small as well. And we began a discussion that day about, baby hasn't expired, how do we plan delivery? They had not thought about what to do with baby, and baby's in a breech position, which is common for babies this because they don't have the mobility with no fluid. And so her decision, with baby still alive, do I have a C-section to deliver baby? Do I let baby deliver vaginally? Even if baby gets into distress in labor and looks like it might not survive the labor process, what do I do? And so we initiated that discussion in part to give her permission not to necessarily feel compelled to have a C-section, that it would be okay to deliver vaginally, even if we lost baby in the process, then we'd support her through that. And unfortunately, whether it was the stress and strain of that discussion that day or simply the timing of what these kids typically do, she went into labor that night. And we'll talk about that. So initially, when these patients get this information, as you can imagine, the distress, the disbelief, the fear, the panic, what now? Oh my gosh. And so they really need time to assimilate this information. She got this information at 18 weeks, had time to develop and think about and decide and evolve in that process, but basically was stuck in this disbelief, fear mode until the next episode where we could begin to discuss that issue, but really did not have the time to begin to resolve and understand and make sense, the time that it normally takes to process the information, understand what their values are, what meaning does this have to their lives, and how did that guide their care at that point. So what happened to her, as I mentioned, is that she went into hospital that night, baby was in breech position, and the physician involved didn't know her, knew of the setting, was somewhat uncomfortable with not intervening because, ultrasound may not be right, this baby may have chance. And I titled this Embers of Hope as a part of a different presentation on that, do we do C-section or not? Because even that little spark of hope, patients will latch onto and clutch to and try to then, well, let's do that, even knowing the outcome and knowing clearly what will happen with this kid. I'm going to go back a little bit to a slide. Making a decision to intervene even in the absence of a baby that's going to survive may be reasonable, provided the patient has thought it through, understands the risk of a C-section, and understands the consequences emotionally of either doing it or not doing it. Being that aggressive may be a reasonable thing to do. There was a point in time where I would say, you have one of these lethal events, you do a C-section, that's malpractice. Okay? I've learned. And when you look at the impact on families, you look at the impact on emotion, having seen mothers who didn't have a baby that was born with a heartbeat, and the consequence of that, there are emotional consequences that may be worse than the impact of a C-section. But that takes time to understand and evolve that. So this particular patient, ultimately because of their inability to understand over time, the anxiety of the physician involved, ended up with a C-section, and not unexpectedly, the baby expired shortly after delivery. And about 2 days later, she was in there, and her questions were, did I really need to have a C-section? And so she was sort of concerned about that. So and part of the frustration on our part is her experience was not an unpredictable experience. These babies with this condition commonly deliver around 34 to 35 weeks. They're commonly breech, and they commonly don't survive. So and about 80% of those babies are actually born alive and do not expire over the course of the pregnancy. So that's the frustration we had, and what sort of got me fired up about this topic and getting involved again. So just to everybody read, take a look at this, a statement by C. Everett Koop in 1980s. And it really kind of does lead us into the whole concept of palliative care. When we have a baby that isn't going to survive, we know have issues. So each newborn infant, perfect or deformed, is a human being with unique preciousness because he or she was created in the image of God. Further in the discussion, he hopes to slay forever the myth that only perfect quality of life is worth living. And also perfectly formed babies are worth carrying through the pregnancy because in certain families they do add value in the emotional makeup of that family. So perinatal palliative care was first introduced into the literature in 1997. It is a coordinated multidisciplinary approach for families who choose to continue pregnancies in the face of a life-limiting diagnosis. In other studies, when patients were given the options of termination of pregnancy versus palliative care, when this kind of a system was in place, 85, 40, and 75% in 3 different studies chose to continue the pregnancy. And in those groups, 2/3 to 3/4 of those babies were born alive that then subsequently expired. So the perinatal palliative care program, if you go back to that study from the families that terminated pregnancy and what were their recommendations, these programs all include those recommendations as a part of it. So there's a multidisciplinary group, there's education provided, there's ongoing support provided. The patients are encouraged to develop a birthing plan that describes what their wants, needs, desires, and that includes method of delivery, how aggressive to be at the time of delivery. Depending on what's going on, do they want autopsy? The whole topic of organ donation of neonates is a very complex topic, and there are sort of this roller coaster of yes, it's available, no, it's not available, so it's still evolving at this point in time. Care of the mother. What happens to a mother when the mother dies but starts lactating? So she's making breast milk. What do you do? How do you support her? How do you prepare for that kind of insult after injury, if you will? Here at Hoag, what we have is a system. There are several systems around. The system here at Hoag is we, once a month, convene a group. It's a maternal fetal medicine case conference, very much modeled after a tumor board. And we assemble most of the specialists that you see in this group, and we talk about patients that have been referred to us or that we're evaluating that we see to begin to develop this plan. That meeting involves both mothers and their conditions and babies and their conditions. And we sort out, depending on what that is, what a plan of care would be. Following that, we then convene a smaller group that includes the mother and the family, usually the primary obstetrician and care provider, neonatologist, any other subspecialists that have been involved. And we had one fairly recently where baby had a complex heart defect. We had the mother, the family, the nursing team, the neonatologist, myself, the obstetrician, and the pediatric cardiologist on the phone on a call-in, and had a discussion. Yes, it's okay, given what we see, it's okay for this mom to deliver at Hoag, which we really wanted to do. We can provide the support based on the anatomy that we see. We're not going to have to deliver baby and then send baby off to CHOC. So we had that care, and ultimately, fortunately, things went as anticipated with that care. So there's the bigger group. At St. Joseph's, they actually have a formalized credentialed perinatal hospice program, and that is licensed as a hospice program with nurses that can actually go out to the family members in the home, educate, be available. They take a little different approach, and they have the family attend the great big meeting with lots of providers there. Some of the comments is that's pretty overwhelming for families to be in that environment. So we've taken the approach of let's do the groundwork first, then we involve the family in a smaller discussion and really evaluate their needs more than what do we think the medical care ought to be, and then relay that to the family. Developing protocols, providing community care support, referencing the appropriate literature, giving that education, those are all parts of this program. Clearly with the benefits that we talk about. So let me segue a little bit into, so that's the care that's provided up to the point of delivery. Mom delivers, and now we end up with a perinatal loss. The effect and grief associated really does not matter when in the pregnancy that occurs. Doesn't matter whether the pregnancy was planned or not, or whether the baby was desired or not. All of those ultimately have a profound impact in that loss. So you're all fairly familiar with the phases of bereavement. We'll just review those quickly. There's the initial shock and numbness, and you can see by the pattern, this is what occurs at the beginning, as we talked about, sort of this, deer in the headlights, stunned, what do you mean, I can't think phase. That evolves into the searching and yearning. Are you sure you're right? Why is this happening? What can we do about it? All of those kinds of responses and emotional turmoil. Being disoriented, now what? I'm going to have this baby, how do we prepare? This is now totally different than what I had planned. How do I begin to process and make sense of this? And then ultimately beginning to reorganize that. And you do see an evolution of these. Well, at times we thought that these phases were sequential, that you would move from one phase into the next as you went through. And really, if you look at the timing, the pattern, those are all happening at the same time. So these folks are in this huge emotional turmoil, trying to sort things out. One of the things that is key is when you look at the anniversary events. So you look at a year out, pretty much always at that anniversary, there's a spike and a return of many of those initial emotions, understandably, as to what's going on. What do you say to these folks? Well, don't be afraid to be emotional. It's an emotional time. And so letting yourself feel and be there with the patient is okay. It's okay to ask about the birth experience. It's okay to ask for looking at mementos, or if they want to show you a picture, and that's okay to do that. It is okay to say, I don't know what to say. I wish we could have a different discussion. We just tell me how you're doing if you have the time and want to open up that question. Don't think because they're acting normal that they're over it. They may just be putting on a brave face. They may still be in shock, whatever. Do use the baby's name. If they've named the baby, it's okay to use that. What you don't want to say are all the platitudes that we're accustomed to trying to say, because almost none of them will ring true. For those of us that have had losses, we know that. And you realize that all these other little things just, you can have others. No, I want this one. You can have an angel in heaven. No, I want that child here with me. Probably one of the things, even if you avoid these that we hear, and even if you have had an experience, is to say, I've had a loss, I know exactly how you feel. No, you don't. You don't have the background, you don't have the experience in that person's shoes, you don't have their emotional well-being, or their troubles that they've sorted through. You haven't developed the same anticipation. So during this process, they're creating future memories, or what will be memories, by planning, anticipating, looking forward. All of those thoughts, because they can't be realized, now become the only memories they have, which are going to be different than anybody else's. It is okay to say, I've had a loss too. I know this is hard, and we're going to be there for you and help you through. Whether you feel secure enough or comfortable enough with that particular patient to share more details may be reasonable to consider, but remember, this is their journey. And it's not, and very often they'll start sort of reversing the roles and saying, I'm sorry, how do and you don't want to really get them in that thought process. You're really trying to support them. So be careful if you're going to share to not push in that direction. Families can all do the same sorts of things, especially remembering the anniversary dates and not being afraid to review those mementos with them. So you want to deliver, so our goal when we have the information is to deliver the information timely, as soon as we can, and as sensitive a way as we can, and yet as directly to get them focused on the things that they need to do. They need to have time to process. And it's not unusual, a patient will come in and will have a demise diagnosed, and we'll tell them at that point in time, you know what, there's no absolute benefit to delivering right now. You're going to go through another rough emotional time at time of delivery, so if you want to take a day or two and process this and then come back in later, that's fine, as long as that is true. You know, there was a time where we would wait until moms went into labor, even though we had diagnosed a demise 2, 3, 4 weeks prior to that. We now have tools that allow us to more effectively induce labor, so we don't have to moms through that, but they don't need to do anything immediately most of the time. I'll let you look at and sort down this perinatalhospice.org is a good resource for more information about this topic. And now I'm going to turn the rest of this over to Dr. Wen. Thank you.
Thank you, Dr. Marlin. Now, I'm going to talk about end of life for the rest of us in this room. The objectives is, I'm just going to be brief and just share with you about what we want for our patients as physicians and as medical providers and what we hear from them. And I'm going to talk a little bit about the myths about palliative care and end of life discussion, because when we do this kind of work, there's a lot of misunderstanding of what we do. And I'm going to introduce you to the CARES team here at Hoag. And with every specialty, there's always a really nice, cool tool with all these high tech. Well, in palliative medicine, we got the POLST. And we'll talk a little bit about that. So we know that there's been, for the past 5 decades, there's this explosion of interventions, and we are actually prolonging life, and people are living a lot longer. We're improving their symptom burden as well. But as you can see, that it also adds a lot of ethical complexity, the cost of moral distress, and how do we balance between beneficence and violating do no harm or non-maleficence. Quick example, for cardiologists in this room, that's one of the highest and the fastest rate of new technology that we have is, we have 81-year-old patient admitted to the CICU with high-grade heart block. And he's considered for a permanent implantable pacemaker, and he's got a pretty slow heart rate, and we feel that this can be augmented by transvenous pacing. But when we look at the history, this patient has pretty advanced dementia, he has diabetes, lives in a skilled nursing facility, speaks very few words, hardly ever communicates with his family, and barely recognizes them, and does not even participate in the activities of daily living. So he sits there, he's incontinent bowel and bladder, and doesn't do much, or maybe he's able to feed for himself. So, of course, we have pacemakers and ICDs. Well, these technologies we know are within the standard of care for many patients with cardiac disease who met these set criteria. So the question we have is there a moral obligation to treat patients because we have these technology? And what about the patient autonomy? I'm just posing these questions because I'm not going to come up with the answer for you, because there's more questions that we need to answer before we make these kind of discussions, these decisions. So however, this highlight the importance of needing to go through and really asking those difficult questions. So let's answer what we want for our patients as physicians and as clinical providers is we want good clinical outcomes. We want to make sure that patients are going to go home from the hospital and stay out of the hospital. But we also want to be able to reduce the fear of the future, kind of calm them to provide support for them and empower them through education. But what we often hear from patients and family is their fear of the future. And as physicians, do we spend that time and ask them, or is it easier to just go through with our day and prescribe and do what we do best? And oftentimes we do hear that patients would tell us that, we wish we know that there are other services out there provided to us, that we know what our options are. So the option is palliative care. So what about some of the roadblocks? I mean, palliative care is, is it the best thing since apple pie? Well, for some it is, for others it's maybe a curse of medicine. But however I see this is palliative care is a gift. But as a gift, there are myths that are surrounding this, and we need to, as professionals, we need to have a very clear understanding of what it is. So palliative care often is seen as, well, it's comfort care, it's end of life, it's hospice care, it's about stopping all curative treatments. And as a practicing hospice physician, when I started my career 20 years ago in hospice, I was very passionate about hospice, and I continue to be. But I understand, too, that palliative care stem from hospice because it was the right thing to do, but palliative care is really going upstream. And we often hear in the hospital, too, from nurses and from colleagues, our colleague physicians, who basically says, look, families, they're not ready for hospice care. They're not ready for hospice care. They're certainly not ready for palliative care. And I try to be gentle and ask, what do you mean? Can you explain to what palliative care is? But we often get lumped into, well, you know, we're going to get palliative care involved. All you're going to do is make these patients DNR and not resuscitate. And my answer is, we're not here to make people DNR. We are here to make sure that these patients have a voice and that they're making decisions that are consistent with their values through thoughtful conversation. Other myths around palliative care is, you know, just call palliative care when the patient's actively dying, and call us in to have these end-of-the-road meetings, and maybe we can cure them. Not really. But also, palliative care is often seen as a hospice discharge or a hospital discharge planning service. There were 3 studies that were presented in the past 6 years regarding palliative care in the hospital, at home, and outpatient settings, and all 3 of those studies have shown an improved patient family satisfaction with the support. There's improving quality of care, and there's no difference in mortality. Often we think that if the patient goes on palliative care too soon, we kill them too quickly, or the patients die too quick because all we do is put morphine and Ativan and make them DNR. We also see in terms of utilization is that we saw a decrease in ICU readmits, increase in hospice length of stay, decreased cost, and this has been very consistent. So there were some other study done this past year. There were questions posed to the lay public when they asked, okay, what is palliative care to you? What is end-of-life care? You know, what do you feel? What do you hear? And so the responses varies. So some people said, yeah, palliative care means you're not getting better. It sounds, no, end-of-life care sounds a bit frightening, or a lot frightening. But I like the word palliative care because it's gentler, but however, it's more confusing. You often hear that. And some people be very honest and say, I have no idea. And some people say, oh, palliative care. Well, it's a beautiful place where worries and care would be hidden away. And this is, yes, I wish I was at the palliative care. But however, palliative care is a lot more than that. And so we need to understand the old approach of how we integrate palliative care support. And traditionally, curative and comfort care and hospice are very well categorized. One day you're in curative care, and the next mode, well, you're going to go on comfort and you're going to go on hospice. So there's not a really clear delineation of how to incorporate this. So the more integrated approach that we're proposing, and we've been working at this for the last 10 to 12 years, is how do we integrate palliative care support along with curative and restorative approach. And as you can see, those zigzag bumblebee type of line is, while the patient is getting curative or restorative goals, the palliative care support should be along with the patient. There are times when there's going to be a lot more palliative care support. There are times when we need to back off. And it's not unusual for our team when we're involved in caring for patients that we feel that we have done our job, we've clarified the goals of care, we have the pain and symptom management under control, we will step away from the case and we can continue for the patient to continue with their restorative goals. So there is this differentiation with what palliative care, what hospice is. This palliative care can be seen as this big oval orange circle or orange oval here, and hospice care is that component. While palliative care stems from hospice care, hospice is only one component of palliative care services. So hospice care is defined by the Medicare benefit with someone having a life expectancy of less than 6 months. And the question is, it's really ... if the illness follows its normal course. So no one in this room really have a crystal ball and say for sure that these patients have a prognosis of less than 6 months. But all Medicare is asking us to do as physician is, in your opinion, doctor, what is this patient's probability of living for the next 6 months? If the probability is greater than 50% that the patient would die in 6 months, then consider hospice evaluation for these patients. And however, when the patient goes on hospice, they have to waive the curative treatment. And waiving here is oftentimes, we see this oftentimes in the oncology realm when patients are still pursuing chemotherapy, 3rd line, 4th line for months on end. However, if the patient's receiving palliative treatments for chemotherapy or radiation, they're completing that course, and there's only maybe 1 or 2 treatments left. So most hospices are very reasonable. They will support that because the frame is how to integrate palliative care and hospice care for these patients while they're finishing up their treatments. So I just want to share this slide. I think will explain itself pretty well. So there was a definition of what palliative care is, which I found to be very, very helpful to what we do. Is palliative care is specialized medical care for people with serious illness. And the care is providing for patients to relieve them from symptoms, pain and stress of a serious illness, whatever the diagnosis. It doesn't matter if it's cancer or cardiac diseases, it could be dementia or other neurological diseases. And the goal of palliative care is to improve the quality of life for not only for the patient, but also for the family. And it's also provided together with curative treatments. And it's provided by a team of doctors, nurses, and other specialists who work with the physicians, other doctors in the team to provide the extra layer of support. And I love the term extra layer of support. And in the team, we often talk about, we want to make sure that we're not an extra redundancy to the care of the patient. We want to bring value, we want to bring quality, and we want to bring good outcome to our referring source and our customers, which is not the patient, but also the referring physicians and the colleagues, as well as the hospital, who is our customer. So a few years ago, we changed, actually a year and a half ago, we changed our palliative care service here at Hoag to CARES. We hope that, we want to exude to you that we do care about patients and we do care about the work that we do, and we want to collaborate with you. But oftentimes we get clumped in and say, well, you're still palliative care, which we are. We're not trying to transform ourselves to something else, but we want to be able to go to the public and say, look, we do care about your situation. And so CARES stands for Counseling on Comfort for Patients and Family. We assist with advanced care planning, relieving pain and suffering, educate about their care options, and other things besides. When we talk about care options, I usually talk about the benefit and burden of pursuing the treatment, as well as the benefit and burden of not pursuing the treatment. So really the option is not 2, but there's 4 options there that the patients and family need to have that time to be explained, to be explained to them. And S stands for support for family members. So I'm the proud supporter of the CARES team, and our team has continued to grow, and I am very deeply appreciative of wonderful colleagues and team that I have here at Hoag. And we came up with a mission statement that, what we're here to do is to provide ongoing education, support, as well as consult to our healthcare partners and professionals, the seriously ill patients and their families, to minimize suffering and improve quality of life. And you notice here that we didn't use the word terminally ill patients, but we used the word seriously ill. So when do we get called in? We get called in oftentimes for our partners, our hospitalists, intensivists, and cardiologists and others, is, when patients' symptoms are out of control, we often get called in where there's family conflict amongst the family members, where the mother and the daughter are concerned about how to best care for dad. And the reason why I was coming down here a little bit late, because I was in that family conference, and sometimes I come in, I'm going to spend 30 minutes with this family. Well, I ended up with 45 minutes, and so it's just, we never know. It's just how to just be there with the patients and family and just kind of guide them through the course of this conflict. And we often get called in where there is a conflict between the physician and family. Physician itself, we realize what the outcome is going to be, but the family and patient will ask, well, isn't there something more you can do? So how do we reconcile those differences? And then we also have an outpatient palliative care service with social worker staff to provide an ongoing psychosocial support. And we also have a palliative care clinic where we do symptom management. So this is a place where I guess I will share with you about, we have a CARES program, but within the CARES program, what we're planning to do is to have the line of service called symptom management service line, because we want to let you know that we do symptom management, and we're not going to be, your patients are not going to us so that we can tell them to stop their treatment and make them DNR. It's about making sure that they are getting the support that they need. So CARES address the gaps in medicine, and the gaps here that we often see is this thing called advanced care planning. It's a continuous process that should start long before the advanced illness. And this week, earlier this week on April 16th was National Healthcare Decision, where Hoag and partners in the community, we had a program of inviting the public to come to participate in this advanced care planning with us, and we call that the Conversation Cafe. And it was very well attended. It was one of the beauty was that Dr. Jack Cox was there. He shared his personal story, because the public is hungry. They're hungry to hear from physicians, and we are able to reach out to the community to say, look, this is what we can do for you here at Hoag. And the goal of our palliative care service is really to go beyond the 4 walls of a hospital, to go out to the public. So Dr. Cox spoke about his perspective as a physician and as a patient, someone who suffers and is going through cancer. And we have Dr. Myla, who spoke on his experience as a physician, but also as a family member. And the curse of having such knowledge as a physician is, we are cursed with knowing too much and realizing what is to happen to our family and to our loved one. So he shared that very emotionally touched story with how he lost his mother. And then we had Dr. Barney, who's our intensivist here. He came and presented to us from to the public about, the intensity of caring for these patients in the ICU when goals of care are not well established, and we watch the turmoil and the emotional disturbances or the stresses that family goes through. And we also see not only the patient and family going through the distress, we also see the distress with our own staff caring for these patients. And oftentimes these are the silent pain that I see ourselves as the walking wounded, but how do we take care of better ourselves? And the only way we see that is, let's try to help these patients and family have this early conversation. So advanced care planning is really to protect ourselves, to support our loved one, to personalize care, strengthen relationship, and in this day and age of accountable care acts and organization is to use our medical sources more wisely. So then why, it was interesting, and then one of the questions that occurred at the Conversation Cafe is that why don't physicians have end-of-life discussions? So there's a study that talked about this. The myth is, well, it makes people depressed. If I bring up end-of-life care for patients, it's going to depress them. It's going to take away their hope. And by the way, I think palliative care and hospice will reduce the survival. And we know there's multiple studies out there that when patients have the extra layer of support with hospice, with palliative care, actually patients live longer. And there was a big study done by the New England Journal of Medicine for oncology patients where these patients actually are less depressed, symptoms are well managed, they live about 4 to 5 months longer than without the disease, without the intervention. Other myths as well, we don't know a patient's prognosis, but usually we do. We have a hunch. We may not be able to say, well, within the next day or the next few hours you're going to die per se, but we have a hunch of what these patients' prognosis is. And it's not culturally appropriate on myths, but the real truth is that we don't like to have this discussion because they are hard on us as physicians. It's time consuming, it's emotionally wrenching, and we don't have a pill for this ill rather than just being there for the patient. But we know some truths about end-of-life discussion based upon these 2 studies is that end-of-life discussion was associated with no increase in patient depression or worry. Actually, the patient and caregiver had a better quality of life, decrease in resuscitation, ICU admissions, and decreased costs, and less depression for the bereaved caregiver because they were supported throughout this. And more aggressive treatments, of course, we see that with, even though there's no differences in mortality, patients, even though there's no difference in mortality, they had a poor quality of life. So the tools that we have in palliative care is not echocardiogram or MRIs and all this latest technology. It's about Advanced Healthcare Directive and the POLST. Low tech, high touch. And so this is the advanced directive of POLST. And those who know me, I'm a big POLST proponent, especially for those who are who have serious illness in the last year of life, because they're the ones that's going to be bouncing back and forth to the hospital. And we know the ED and the ICU and the hospice and the intensivist oftentimes will ask ourselves, what does this patient want? So on the side of medicine is we err on the side of life, which is not a bad error. But we want to make sure that the treatment we provide for patients, again, are consistent with their goals and preference as well as values. So these are opportunities. It's the right thing to do for a patient. It's team-based care, improves values. And I just want to end this slide with Dr. Maya Angelou, who shared with us that, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. So Dr. Mills and I, please come up here. Dr. Mills, we share with you a lot of information. There's about 64 slides that we threw at you in the last 45 minutes. And so you probably pick up a few things. You probably forget that, we stumble up here a bit, but we hope that you don't forget how we made you feel in terms of, there are services here at Hoag to provide for patients, to provide the best care possible through their illness, be it little kids who have not been born yet, and to all of us in this room. So thank you very much.